Hello, and welcome to Back to the Science. I'm Dr. Susan Oliver, and I'm a scientist, and this is Cindy Oliver, and she's a dog. I started this channel a little over 2 years ago with my beautiful dog, Julie, who I miss very much. And at that stage, pretty much everyone had accepted that hydroxychloroquine didn't work and had moved on to ivermectin, which we now know definitely also doesn't work. So I've never really covered hydroxychloroquine, but suddenly it's back again in the crankosphere. So in this video, I'm going to briefly go over the history of hydroxychloroquine from a science point of view, as well as look at the paper that is getting people excited about it again. And finally, I will look at a new study that has attempted to quantify the harms that occurred from using hydroxychloroquine early in the pandemic. The scientific interest in hydroxychloroquine started with two studies. The first study is this one here, which was an in vitro study published in March 2020 that showed that hydroxychloroquine was able to inhibit SARS-CoV-2 infection of cells. And this study was a follow-up to a previous in vitro study from the same research group that looked at in vitro effects of chloroquine and Remdesivir on SARS-CoV-2 that was published in February 2020. And there was also an open label non-randomized clinical trial published in March 2020 from the laboratory of Didier Raoult, whose name I've probably butchered, so apologies, Professor Raoult. But that study purported to show that hydroxychloroquine treatment was significantly associated with viral load reduction or disappearance in COVID-19 patients, and that its effect was reinforced by azithromycin. Just over a week after this study was published, hydroxychloroquine was given emergency use authorization in the US. But then cracks started to appear in the story. A number of scientists, including Elizabeth Bick, uncovered several issues with the clinical trial. For instance, 6 patients who were assigned to take hydroxychloroquine were excluded from the analysis because they didn't take hydroxychloroquine for the whole 6 days. Sounds fair enough, except the reasons for non-completion were that 1 patient died, 3 were transferred to the intensive care unit, and 2 withdrew. None of the 16 patients in the control group died, withdrew, or needed care in an ICU. As the trial was not randomised, there were also confounding factors as the two groups were not the same. And in particular, patients who had an exclusion criteria such as a medical condition that would put them at risk for treatment with the drugs were assigned to the control group. Also, although they were supposed to be testing how many patients were negative on day 6, not all patients were actually tested on day 6. And these issues were subsequently recognised in an official statement from the International Society of Antimicrobial Chemotherapy, or ISAC. And they stated, ISAC shares the concerns regarding the above article published recently in the International Journal of Antimicrobial Agents. The ISAC board believes the article does not meet the Society's expected standard, especially relating to the lack of better explanations of the inclusion criteria and the triage of patients to ensure patient safety. And then it turned out that the in vitro research that showed hydroxychloroquine had antiviral properties couldn't be extrapolated to SARS-CoV-2 infections in people. The initial in vitro study was done in monkey kidney cells. Now, I'm sure you all know SARS-CoV-2 doesn't typically infect kidney cells. It infects lung or airway cells. And we're not monkeys. Does this really matter? Well, yes. Viruses can only replicate by entering and then taking over the machinery of cells. And how they do this won't necessarily be the same for all cells. In this study, which was published in July 2020, they found that although hydroxychloroquine and chloroquine were able to inhibit SARS CoV 2 in monkey kidney cells, they didn't inhibit it in human lung cells. And the reason for this was that SARS CoV 2 is only able to enter monkey kidney cells through one route, and this route is blocked by hydroxychloroquine. However, SARS CoV 2 can also enter lung cells via a different route, and hydroxychloroquine has no effect on this route. So, what this means is that there is absolutely no in vitro evidence that hydroxychloroquine works for COVID. Now, at the time this study was undertaken, it was still possible that it could work by some other mechanism that was not directly related to its action on the virus, like an anti inflammatory effect, for instance. Generally, in order to determine if a treatment is effective or not, is to conduct what is known as a randomized controlled trial. What happens in a randomized controlled trial is people are randomly assigned to one of two groups. And this randomization step is critical because without it, you don't know whether your two groups have differences that will affect their outcome. One group is given the treatment, and the other group is given a tablet that looks identical to the treatment but doesn't actually contain any medication, otherwise known as a placebo. You then compare the results of the two groups and see if there is any difference. And it just so happens that a number of placebo controlled randomized trials were conducted for hydroxychloroquine. This study here looked at randomized trials for both hydroxychloroquine and chloroquine and included 28 trials altogether in the meta analysis. Hydroxychloroquine was evaluated in 26 trials and chloroquine was evaluated in 4 trials. And if you're wondering what the author correction was, it was just someone's name was spelt wrong. They found that treatment with hydroxychloroquine was associated with increased mortality in COVID-19 patients, and there was no benefit with chloroquine. The combined odds ratio for all-cause mortality for hydroxychloroquine was 1.11, which means that patients had an 11% greater chance of death if they took hydroxychloroquine. Now, although this was a meta-analysis of a large number of trials, the results were dominated by 2 trials, Recovery and the WHO Solidarity trial, which together accounted for 88.9% of the results. And these trials were both criticised by hydroxychloroquine fans because it was claimed that the doses used were too high and therefore were toxic. The fans claimed that if lower doses were used, then hydroxychloroquine would have been effective. This is rather ironic given that the opposite argument is used for ivermectin, with ivermectin fans claiming that only doses considerably higher than approved doses provide any efficacy. But hey, who says you have to have the same argument all the time? Now, hydroxychloroquine is used to treat a number of conditions, but the highest approved dose is used for the treatment of malaria. And if you compare the doses used in the Recovery and Solidarity trials with the dose for malaria treatment, the doses are the same for the first dose, but the doses used in the trials are slightly higher for subsequent doses, although not astronomically so. But hey, it does make sense to see if hydroxychloroquine works at a lower dose as suggested by hydroxychloroquine fans. And that's just what they did in this trial here, which looked at the effect of hydroxychloroquine on clinical status at 14 days in hospitalised patients with COVID. This was a randomised trial that was undertaken across 34 hospitals in the US. And the dosage used was much lower than that used in the recovery or solidarity trials. 400 milligrams twice daily for 2 doses, and then 200 milligrams twice daily for 8 doses. The primary outcome was a clinical status score at 14 days. And they found no difference between hydroxychloroquine and placebo, with both having a score of 6. They also looked at specific endpoints after 14 days and 28 days, and there was no significant difference in any of the endpoints. One of the endpoints was death, and as you can see, this occurred in approximately 10% of patients after 28 days, regardless of whether they got hydroxychloroquine or not. So, after this study came out, most hydroxychloroquine fans did finally accept that it didn't work.
But from this, we can say it's not efficacious in patients that are hospitalised with the inflammatory complications of COVID-19. So I think that is the end of the discussion, really, of hydroxychloroquine as a therapeutic for poorly patients. 3 trials now. The first 2, the doses were too high, could have skewed the results. This trial, the doses appear to be just right, consistent with what clinicians are practicing in Italy and Belgium, and it didn't work. It's that simple. Pity, because it's cheap, readily available, can manufacture it by the ton, but it doesn't work.
Luckily for those who just love a conspiracy, ivermectin came along and they could claim that that was a cure that everyone was hiding. We now also know definitively that ivermectin doesn't work for COVID. And if you want to know how we know this, I have a whole playlist devoted to it, and I'll provide a link in the video's description. Of course, some people refused to accept that hydroxychloroquine didn't work and came up with other excuses. For instance, some people claimed that it needed to be used with zinc to work. As it happens, this has also been looked at in a study, and this is a study here. It involved just under 200 patients. Half the patients received hydroxychloroquine by itself, and the other half received hydroxychloroquine combined with zinc. And there was no difference in the trial between the groups. So, zinc doesn't help hydroxychloroquine. It still doesn't work. Still, other people claim that although it didn't work as a treatment, it worked as prophylaxis and prevented the development of COVID in people exposed to SARS-CoV-2. This was also tested in a randomised double-blind clinical trial. It still didn't work. There was no significant difference in the incidence of COVID between those who got hydroxychloroquine and those who got placebo in asymptomatic individuals with direct contact with laboratory-confirmed COVID-19 cases. So, given all this, why are people suddenly claiming that hydroxychloroquine works again and the evil lizard people are hiding it from you? Well, it seems to have started with this paper here, which was published in October 2023. And the corresponding author is none other than Didier Raoult, who published the first clinical trial that started off the hydroxychloroquine craze and was subsequently shown to have serious issues. And it turns out that it wasn't the only study with serious issues. A number of his papers have now been retracted. Now, whereas the studies showing that hydroxychloroquine doesn't work and possibly causes harm are randomised controlled trials, this study is not. It is just an observational study. Now, there are times when it is appropriate to do observational studies, particularly after products have been approved, because to do randomised trials in these circumstances is unethical for obvious reasons. But you need to make sure that you adjust for as many confounders as possible. This hasn't been done in this study. This table here shows the baseline characteristics of the patients in the study. And as you can see, there is quite some disparity in the ages of the two groups. 56% of those patients who got hydroxychloroquine combined with azithromycin were under 50, whereas only 39.9% of those who didn't get it were. And only 8.3% of those who got hydroxychloroquine combined with azithromycin were aged 70 to 89, but 20.9% of those who didn't get it were. So the data is skewed towards those younger getting hydroxychloroquine and those older not getting it. Now, this is, of course, a major problem because all other things being equal, the older you are, the more likely you are to die from COVID. Now, the authors of the paper did correct for this somewhat, but it was impossible for them to correct for it fully because the only age information they had for each patient was their age band. Therefore, people aged 18 would be treated the same as people aged 49 in their calculations, and people aged 70 would be treated the same as people aged 89, even though their risk of death would be very different. And we also know that anyone who couldn't take hydroxychloroquine because it was contraindicated were automatically in the control group. But these people would generally be at higher risk of dying for COVID. In a randomised trial, they would just be excluded from the study. So in other words, the results of this study are total bollocks because the treatment and control groups are fundamentally different. But there were a few results that gave me a bit of a laugh. They looked at the mortality effect of a number of conditions, and one of the conditions that they looked at was being vaccinated. And as you can see, being vaccinated was much more effective at reducing mortality than using hydroxychloroquine. And whereas there was a skew to younger people taking hydroxychloroquine, COVID vaccination is generally skewed the other way, with older people more likely to be vaccinated than younger people. And this would be particularly the case during the study because it includes a time where vaccines were being rolled out and the elderly and other vulnerable people were eligible first. Equally amusing was this figure here, where they looked at the effectiveness of different COVID treatments and conclusively showed that ivermectin was not an effective treatment for COVID. Oops. Another interesting read was the competing interests section. Didier Raoult did declare some competing interests, but none of the other authors did. This is what they said. PBMM and PMC declare no support from any organisation for the submitted work. No financial relationships with any organisations that might have an interest in the submitted work in the previous 3 years, and no other relationships or activities that could appear to have influenced the submitted work. PMC just happens to be Peter McCulloch, who just happens to be part of the wellness company, who just happened to sell a contagion emergency kit, which just happens to contain hydroxychloroquine and azithromycin. I don't know about you guys, but that sounds like a competing interest to me. By the way, the kit costs $299.99 for 4 generic medications and a nebulizer. Who says selling generic drugs isn't profitable? So hydroxychloroquine doesn't actually work. But what's the harm? Well, there were 2 main causes of harm from inappropriately using hydroxychloroquine to treat COVID. Firstly, hydroxychloroquine has legitimate uses. For instance, it's used to treat lupus. This study here was conducted amongst lupus patients in Europe, and it found that 51.8% of them experienced difficulties obtaining hydroxychloroquine during the first wave of the pandemic. The study also shows that the unavailability of hydroxychloroquine generated high or very high anxiety in 56.1% of patients. And even when supply resumed, 27.4% were still anxious about ongoing supply. The other issue is that hydroxychloroquine didn't just not work. The systematic review that I showed earlier in the video showed that it actually increased mortality. And recently, this study has estimated that its use led to 16,990 additional deaths in 6 countries in hospitalised patients early in the pandemic before it was shown not to work in randomised controlled trials. Although I have to emphasise that this is only an estimate. There are a lot of limitations with the study, so the real value could be substantially more or substantially less. So the way they came up with the number is they calculated the number of deaths in hospitalised patients by multiplying the number of hospitalised patients receiving hydroxychloroquine by the mortality rate of each country. The number of deaths related to hydroxychloroquine exposure was obtained by multiplying the previously estimated number of in-hospital deaths per country and the odds ratio of hydroxychloroquine-related mortality, which came from the systematic review that we previously discussed. But as I said, there are a number of limitations that mean the estimate could be way out. And the authors recognise this. And I will just read out what they said in this regard. Thus, hydroxychloroquine-related deaths may be considerably over or underestimated. Indeed, 95% confidence interval of the odds ratio of all-cause mortality related to hydroxychloroquine ranged from 2% to 20%. In other words, our results might be overestimated by a factor of 5, i.e., the actual number of deaths related to hydroxychloroquine would be approximately 3,000 deaths, or underestimated by a factor of 2, i.e., the actual number of deaths related to hydroxychloroquine would be about 30,000 deaths. What is important, though, is that although we don't really know how many people died from inappropriate hydroxychloroquine use early in the pandemic, we do know that some people did. And we also know that those who chose to continue using it even after it was clear that it didn't work contributed even further to excess mortality. And in some cases, they are still doing it. If you'd like to look further into the data I've presented, I provided links in the video's description. And please remember this video is about the science, but you shouldn't take it as medical advice. For that, you should speak to your medical practitioner. If you've got this far, thank you for listening. And if you've liked or commented on the video, double thank you, because that helps the algorithm and means that more people will see the video. And of course, thank you to everyone who has bought me a coffee or little Cindy here a treat. Cindy, there's a treat. No, she's not even going to wake up for a treat. Oh, well. Anyway, oh, there she has. There we go. There we go. We really appreciate your support. And we will be continuing to make videos about the science in the future. So if you'd like to join the cool kids and stay informed, please hit the subscribe button. And also, just in case anyone's wondering why I've got this funny thing on my wrist, I damaged the tendons in my wrist when I was picking Cindy up in and out of the pram when she hurt her paw. So it's nothing serious, but I just have to wear this because otherwise I just keep sort of re-hurting it again and again. So, but hopefully it should be better in a few weeks. Anyway, thank you again for listening. See you later. Bye.